Yeah.
So it's still February 2nd and Friday, and we are returning to S18. We are going to start off hearing from Dr. Gogo from the University of Vermont Larner College of Medicine. We had tried to have two other witnesses also this morning. Someone to talk about sort of the economic impact on businesses of this, and someone else to talk from the health department to talk about sort of financial savings to the state as a result of this bill. But that is going to happen next week. And so, but really looking forward to hearing more about sort of the financial impact of tobacco and possibly tobacco banning from Dr. Gogo. Welcome. Thanks for joining us.
Thank you. Thank you very much for allowing me to speak to you guys today. So my name is Prospero Gogo. I'm an interventional cardiologist at the University of Vermont Medical Center. I'm also the director of the cath lab section. So that's the section of the hospital where we perform procedures, basically a cardiac plumber, if you want to put it that way, where we open up blocked arteries that are causing heart attacks and also a lot of symptoms such as angina in many Vermonters. So my role in this is to go over a tiny facet of the cost of smoking-related disease on Vermonters. And so I'm going to use the data that I have from the hospital, as well as some of the state databases, focusing primarily on cardiovascular disease. And again, this is a small portion of the spend the state and federal payers place on taking care of Vermonters with smoking-related diseases. So with your permission, I'm going to, well, I have a slideshow if you want to see it, if I'm allowed to share my screen.
Yep,
Could someone allow me to do that?
Saoirse will make that possible right now.
Thank you. Okay. So.
But do you not have? Oh, and
Yeah.
Can you also send the slides when you're done sharing with us so that we can have them for the record? Thank you so much.
Absolutely. Okay. So anyway, I just wanted to go. So the point, of course, is that vaping and smoking harms Vermonters in many ways. I'm going to talk about the financial impacts on the payers for the healthcare system, but this does little to show you the actual harm that's going in terms of morbidity and the suffering of Vermonters, as well as death of Vermonters related to smoking. So this is a small slide looking at the case mix. So on the left is a pie chart of the number of procedures that we do per year at UVMMC in terms of total stent procedures, 1,014 per year as of fiscal year 2023. And then on the right is a comparative sample of the total number of PCIs, that's stent procedures, in this nationwide database that we participate in called the NCDR. As you can see, we're a small fraction of the total number of PCIs nationwide. And that also calls to attention the total number of, I mean, we're a small facet. And this actually, if you look at 700,000 procedures per year, remember 50% of people who have cardiovascular disease have a history of smoking. And so 1,014 is the number of stent procedures per year. The pie chart really shows you the difference between elective and myocardial infarction. Okay, so elective procedures for patients who have a little bit of chest pain here and there, but it's impacting their quality of life, where they can't do things like manual labor tasks or even do things like exercise. Whereas myocardial infarction is the indication for a stent when someone's having a heart attack, and we're doing the stent on the short term to improve their quality, on the short term to save their life from the heart attack, as well as on the long term to improve their quality of life and prevent heart failure and other things. So we take those 1,000 patients who got stents per year, 678 of those are heart attack patients. And so this is the chart where I wanted to show you how that divvies down. So it's 678 patients with heart attacks. 31% are the larger heart attacks, and 69% are the smaller heart attacks. We call the large heart attacks STEMIs, STEMI. That's the way that's ST elevation myocardial infarction. It's a finding on an EKG, which indicates there's a large heart attack going on. And then 69% of the 678 patients have smaller heart attacks initially. And again, mind you, from the Vermont Behavioral Risk Factor Surveillance System, 56% of Vermonters with any history of cardiovascular disease are smokers. And then if you look at our own data at UVMMC using the CAF PCI database, 40% of patients presenting with myocardial infarction requiring stenting are current smokers. And this is not a cost slide. This is actually an outcome slide. And this is from our database that I will be presenting to our own hospital next week. But this is the outcomes of large heart attacks. So this is us at UVM versus the United States. And we have this is called a risk-adjusted model, meaning trying to factor in as many comorbidities as possible and do an estimated mortality risk. So about 3% of people die from myocardial infarction prior to discharge. Nationwide, that puts us comparable to our peers in terms of outcomes. But 3% of all these patients will pass away before even being discharged. So this is a slide that's really going to get at the cost of all this. Now, these are big numbers, and these are not the biggest of numbers. So those 5-digit numbers you're seeing on the slide are Medicare average reimbursements for each diagnosis. The small numbers, the N's slightly above those numbers, are the number of patients that we treat at UVMMC in any given year. This is for fiscal year 2023. And along the bottom, these are labeled diagnoses for each admission. So DRG 246 are patients who get a stent. DRG 266 along the bottom is patients who get a percutaneous valve procedure. DRG 268 are patients who are really sick, who have cardiogenic shock and require a temporary heart pump while they're getting their stents. DRG 280 is a medically treated heart attack, and DRG 281 is a medically treated heart attack that's not too complicated. And then a DRG 233 is someone who gets coronary artery bypass graft surgery. So you can see the numbers range from as high as $65,000 per admission for someone who comes in with cardiogenic shock and requiring a temporary heart assist device. And a valve procedure and CABG are similar in terms of their costs, around $42,000 per admission. And then by far the highest number of admissions are going to be patients who require stents, and that's at $18,000. Again, these are Medicare reimbursements. This does not reflect the actual reimbursement from a private payer such as Blue Cross Blue Shield or Cigna, which tend to reimburse higher than Medicare reimbursement rates. So if we take back of the napkin numbers, we multiply these ends versus the reimbursement, then this is what we come up with in terms of annual costs. We're looking at somewhere around $12.5 million just for the stented patients, $14 million for the CABG patients, and then the smaller numbers for lower numbers. But again, for someone who needs a TAVR, we're looking at a valve procedure, $3.5 million per year. So these costs all add up. And this is just, again, at UVMMC for cardiovascular diagnoses. If we put that all together, we're looking at $35 million per annum. And this is a floor spend, meaning we're just looking at Medicare data for treatment of these things. And we're not talking about private payer data, which tends to reimburse significantly more. So that's just UVMMC, or $35 million per year.
We have a question.
I'm good.
Oh, nope,
Sorry.
we don't have a question. Back to you. So
go
sorry.
ahead.
No, we
All right.
actually, it was a false alarm. Sorry to interrupt you.
Okay. No worries. No worries. This is not a lot. And this is deliberately a quick presentation. And I wanted to make sure that there was a lot of time for questions afterwards, because I'm looking at data, but if you had any other questions about things that I know, I'd be happy to answer any of them. So statewide, if we look at statewide, we have to look at just the medically treated data for heart attack, those DRG 280 through 283. That's for patients who have a heart attack, but either aren't eligible for stenting due to comorbidities or that they just choose not to go for stenting and they're just getting medical treatment. And the reason why we do the statewide is because UVM is the only hospital that does stents in the state. There is some money that goes to Dartmouth because they take care of Vermonters on that side of the state. And again, those numbers for UVMC don't reflect that. $35 million does not reflect Dartmouth's cost reimbursement for Vermonters being taken care of there. But in 2017, this is the Uniform Hospital Discharge database for Vermont. 457 Medicare eligible admissions statewide in 2017, and that's around an additional $5 million for this population in 1 year. Some of those patients are overlapped with UVMMC, of course, but again, I try to get some number that reflects something statewide. And again, this does not include private payers. So 457 patients are just Medicare eligible, and then you could add probably another 200 to 300 of that for private payers. So small snippet of costs, but again, the costs are only having to do with the core red diagnosis in the middle here. And that just again, smoking is the number one reversible risk factor for so many diseases, including all the blue are the lung diseases. Unfortunately, the green is all the cancers that it causes. And then for fertility issues with women, miscarriage, impaired fertility, preterm delivery, congenital malformations in kids, and low birth weight, and plus sudden infant death syndrome, which is associated with women who continue to smoke during their child's infancy. So again, small snippet of a lot of the, but if we're spending close to 40 to 45 million dollars per year in Vermont just for coronary artery disease costs, then you can actually multiply that by many factors to try to take in all the costs that we currently spend for treatment of smoking related disease. So I'll stop there, and I'll take any questions you might have.
Hi, so I noticed that Vermont is, we have a higher rate than the nationwide. Is that, do you believe that's because of some sort of public policy or our demographics or something else that I'm not thinking of?
A high rate of which factor?
I think the percentages of people that are having these procedures done in Vermont. Maybe I misread the slide, but it looked like that we have a higher rate than the rest of the country.
Oh, I'm sorry. I probably went through that very quickly. So
yeah,
you're
right
probably
there.
talking about this,
no,
this right?
It was a
right
bar
here.
graph. No, it's that right there. The bar graph. Yes, that one. Yeah. Did I read that wrong or?
Sorry, I went through this slide very quickly. This is just factoring in the outcomes only of the total number of patients we've treated. And so by risk adjusted mortality, we have a slightly higher, slightly worse outcome than the rest of the country. But again, this is makes it look a lot worse here. This is 2% versus 2.8 versus 1.8%. This ideally should be around this ODE STEMI mortality should be it should be around 1, and so we're slightly worse than most. Part of this is it doesn't factor in some of the comorbidities that we feel we treat with Vermonters. Our age group tends to be older than the rest of the states. So yeah, so I'm sorry, I went through that one pretty quickly.
Okay, thank you. I think I probably read a little bit too much into it. Okay, thank you.
Yeah, no worries. No worries.
Doctor, you have an idea how many of these patients you see every year that do smoke?
Yeah, so I think, so looking at the last database of those 678 stented patients per year, approximately 40% of them are current smokers. And that reflects bad, I mean, that's a overrepresentation of smokers among the heart attack patients. So again, 14% of Vermont adults smoke currently. But 40 to 45% of them coming in of the people who have a heart attack are current smokers. So it's overrepresented amongst the smoking population. It doesn't, of course, that also, you can flip that on the other way. 60% of people aren't smokers who have heart attacks. And there are a lot of other multiple risk factors that can predict whether someone has develops heart disease. That includes diabetes, high blood pressure, and high cholesterol. Those all may reflect vices that we might perceive in the world, such as overeating, that kind of thing. But really, the only vice that is completely elective and there's no benefit per se for doing that vice would be smoking per se. I mean, there are some, perhaps smokers do feel relaxed more when they continue to smoke rather than stopping. But like I said, in terms of other health benefits, you need to eat, for example, and so that kind of stuff. Whereas smoking, I feel strongly about it. There's really no reason to pick it up.
Representative Meadows, Andrews.
Thanks, Doctor. This is kind of a two-part question. Do you have any idea what percentage of that is menthol cigarette users, since that's what this bill pertains to? And then also, how does Zyn play into this? Do you have any idea what that does heart-wise?
Okay, so the first question is what percentage is represented by menthol? And I'm not the best person to, our data doesn't differentiate menthol versus regular tobacco or flavored or anything like that in our data. The data is only plus or minus tobacco abuse or vaping. It does include vaping. So within that data, current vapors are grouped into current tobacco smokers, current combustible cigarette smokers, but it doesn't differentiate between how you're doing that, whether it's flavored versus menthol or anything like that. I can say, and so I would defer to, but I would say that if you take that representative sample of 40% menthol cigarettes, for example, probably have slightly higher risks of developing cardiovascular disease because people who use menthol cigarettes tend to inhale more. Menthol is an anesthetic, and so people tend to inhale more deeply when they have a menthol cigarette, and and there are some studies that show at least more harm from lung-related disease when you use menthol-related cigarettes. So, but I can't tell you what the percentages are. Oh, and the
so
second question was.
Just how does Zyn, like the little pouches, how does that play a role cardiovascular?
You mean the Zyn? You mean a vaping cigarette, a vaping
No, like
products?
the little nicotine substitute pouches, the Zyn, the little
It's
tin
like
there.
gum, but it's like an oral thing. It looks like
I
gum,
see.
but it's actually like almost like you suck on it, sort of.
Yeah. So in terms of harm, so in terms of cardiovascular disease and harm, of course, we have really good data for cigarettes. The thing to remember is that we didn't have that data initially. And in fact, because cigarettes have always been around, for many years, that kind of data was also suppressed by the industry. But we do have very good data currently for smoking, and the lead time for developing heart disease from smoking can be measured in years. So anytime you see a new change in the pattern of habits for smokers, the tail for that is going to be 10 to 20 years before you actually see an effect on the health of the people who are habituating on those things. But we do have some preliminary data for vaping, for example. Since vaping is so new, we don't have the 20-year data for what it causes in terms of cardiovascular health. But we do have our markers for effect on health. And vaping there's a lot of preliminary data showing, for example, early changes on vascular health that are pretty characteristic of the development of heart disease down the line in 15 to 20 years. Oxidative markers, that kind of thing. So there is pretty good preliminary data, which we can either wait for 20 years and see what happens to all these patients with vaping, or we can really use these markers as a marker of caution that these things aren't really well understood. We don't understand the full health effects of these things. And finally, the nicotine substitutes, and I'm not an expert on nicotine substitutes, but from the cardiovascular standpoint, non-inhaled, non-combustible nicotine products tend not to lend as much risk as the inhaled or products. So, and that's one of the reasons why we have a lot of nicotine substitutes for trying to quit smoking within our cardiovascular guidelines.
Thank you.
Thanks. And I want to, you shared that chart with us about the costs, and that was Medicare dollars, I think you were talking about.
That's
Does your
correct.
hospital have anything on Medicaid dollars if we're thinking about sort of state costs?
Yeah, so since I'm kind of low on the totem pole and I'm not in the C-suite, I don't have ready access to those numbers. I'm sure someone from UVMC can get total costs from Medicaid and private payers. I was looking at publicly accessible information with the data that I have within the cardiovascular division. So yeah, I'm sorry, I don't have that particular.
No, it's
data.
okay. We'll ask someone in a different spot in the bureaucracy. Thank you. I think it was Representative Andrews and then Odie and then Sims.
I'm gonna once again withdraw my question because it was about the effects of vaping. I think it was concerned.
Okay. Odie, then Sims. And then Taylor, did I catch that? Okay.
I have a question. I thought I heard you say something about sudden death and the mom's use of tobacco, but would it be anyone near the pregnant person or anyone near the baby once the baby's born, or is it specifically the mother?
It's specifically so this is from the Health and Human Service, from the federal government. and again, I'm not an expert on that side. I was just bringing it in as that big slide for what potential effects. But there's an association of sudden infant death syndrome in infants who are born to mothers who smoke throughout pregnancy and then after delivery. So there's a higher risk of sudden infant death syndrome in those in that population.
Thank you.
You were next, right?
Yeah.
Okay.
Thanks. I wanted to go back to the tobacco substitutes and, given what you were saying about maybe seeing a reduction in health impacts compared to smoking, is there some concern that the ban contemplated here is actually limiting harm reduction options for adults to help with smoking cessation?
So the official word from the Fed right now is that there's not enough data on inhalational vaping as a nicotine substitute to recommend it being something as a smoking cessation device. At this point, that differs from the European opinions and the British opinions. And so on their federal guidelines, you can use those devices to mitigate the addictive effects of combustible cigarettes. So there's a harm reduction aimed for that. The US is being a bit more conservative in that data, and they haven't made federal guidelines yet. I know the FDA was looking at closed system vaping cigarettes as a potential quit, but those would be kind of generic and boring for the kids, right? So no flavors, just a white tube that looks like a cigarette, the nicotine delivery, no additional flavors, no additional other things in that. So that's what they're looking for. The FDA is looking at for a smoking cessation device for adults. So I think the main issue here is that there's a whole other host of factors with flavors, especially, if you think about, and this is from I'm sure other speakers have talked about this, but the substances that are being used as flavors were approved by the FDA for consumption into your gastrointestinal tract and not into your lungs. And so this is leading to a lot of unknowns in terms of the potential harm for vaping these flavors. I can say that if you look, there is one preliminary study looking at comparative risk of recurrent heart attacks in patients who continue to smoke versus patients who successfully quit versus patients who moved over to a tobacco substitute, inhalational tobacco substitute, a vaping device. That data is a couple years old. It was very preliminary, but it suggested that there was a harm reduction if you're on a vaping type device versus versus continuing to smoke combustible cigarettes. But again, the lowest risk for recurrent events were patients who are able to successfully quit completely. So again, I think there's a lot of unknowns on there, but in terms of what's the subject at hand, I think there's really a lot of unknowns for flavors. And then there's also, if we think about the harms to children who are really being attracted to these flavors, I think that's really where the question is.
I would encourage us to remember that the Human Services Committee spent a great deal of time understanding the health impacts of this. We are not going to spend a great deal of time understanding the health impacts of this. We're going to have to trust that they spent a lot of time understanding the health impacts. This is not to you, Dr. Gogo. This is to the committee. You are doing your job over there. But what I will
I would just say that I
that
could go on forever on this
Yeah.
one, so just let me know.
Yeah. And so what I encourage us to focus on, and I know it's a little bit of a gray line, is the cost of the health impacts to the state. That's sort of what we are attempting to balance today. That said, I did, happily inhale many things that were not flavored in my youth. So there are questions there too.
Mine's been answered.
Yours has been answered. Does anyone still have an open question? Yes, Representative Brannigan.
Doctor, thank you for taking time to appear before us this morning. It's a really important question for our constituents. I represent part of Franklin County, which is north of Burlington, between you and Burlington and Canada. And I was discouraged yesterday to discover that Franklin County has the highest rate of consuming these products of any other county in the state. I knew that we had a high rate of smoking up there, but I didn't realize we were the highest in the state. I know that we have troubles with some of the things that you've already mentioned, overeating, well, other things, drinking, and a lot of problems in Franklin County. And I think it has to do with our low average level of education, our rurality, the fact that a lot of our people live out away from other people, and a number of other things. But anyway, I appreciate you coming today to spend time with us. How long is it before, you were talking about a great deal of money that comes into the UVM Medical Center. How long does a person need to smoke before that money starts coming in, before they go to see you for treatment, get the treatment, and then the hospital is reimbursed? Is that a lifetime? Is it a decade? How long?
Well, so I'll put it this way. Smokers tend to develop heart disease at a younger age group compared to the average. So, but the average treated patient for heart attack at the hospital who gets stents is around 63 years old. Smokers, you could probably subtract on average 2 to 3 years, but that still leaves you a lead time of 30 to 40 years before they really are suffering from a lot of this heart disease. And I'd say that's the same lead time for a lot of the cancers you're talking about. So the time to have, and the good news is for many of us is that, I mean, for the state in terms of how much this costs, we've done a remarkable job at cutting down the smoking rates. So over the last 25 years, in the 1990s, for example, we had smoking rates in the mid-20% range, mid-20s, and in the 1980s and 70s, we're talking about 30 to 35% or higher. And so we're going to reap those benefits in terms of healthcare in another 20 years, right? So like we had a huge increase in smoking. I mean, we had a huge drop in smoking probably in the mid 1990s. That's a lead time of 30 years. That's how long it takes. What we're looking at now is if we start a whole new generation of children on this, then we're looking at costs, which, of course, with inflation, everything like that, we're probably talking about billions of dollars in 30 to 40 years. If we get, if the current use of vaping products in the high schools remains through adulthood. I mean, we're looking at 1 in 3, 1 in 2 high school kids in the last survey have used a vaping device in the 30 days prior to the survey. If that rate continues, then yes, we're going to be spending a whole lot more money in 30 to 40 years on patients just for heart disease, not just for heart disease, but for all these other diagnoses that are related. And especially, there's also one paper a couple of years ago that showed that you're more likely to move on to combustible cigarettes if you're already on a vaping product. And so again, even though you're looking at probably less harm on vaping versus a combustible cigarette, you're a bit more likely to take up the habit of going to full-on cigarettes if you already have a vaping habit. So these are all the things that I know this is a committee focused on the costs of these things, and there's going to be some upfront. I understand there's going to be some upfront costs to businesses and to state revenue when you put some kind of ban like this. But it's like a lot of other public health things. You have to invest a little bit right now to save a substantial amount of money in 30 to 40 years.
Thank you, doctor. That's helpful. I have one more question, and you may not be able to answer it, but a few years ago, we legalized cannabis here. I voted against it, but it passed in the House and in the Senate, was signed into law. So cannabis is now legal. Have you seen any impact health-wise from that? It hasn't been very many years. I don't even know. I think maybe 5 at the most. But have you seen any results?
Well, I can tell you that, for example, recidivism within heart attack patients who smoke combustible marijuana is pretty high. It's the equivalent of smoking. So if you're a cannabis smoker, you just had a heart attack, your rate of another heart attack within 5 years is double that of someone who doesn't smoke cannabis or smoke cigarettes. I haven't seen that directly in terms of the numbers per se. I just can be anecdotal about it. But that data in terms of your risk of a repeat heart attack if you're a current cannabis smoker is data that's available in the on government on peer review articles.
Thank you.
And thank you so much for spending time with us today. We really appreciate it. We're gonna pick up more
You're welcome.
testimony on this next week.
Thank you. Thank you for having me.
Yeah, sure.
Just to share with the committee, so my dad died of lung cancer when I was 13. And when he was probably still in his 40s, he had a heart attack. And so I was pretty young. I don't know how old he was precisely. He had the best job he had ever had in his life. He got a GED in the military. He was working on elevator construction. And because that's such an inherently unsafe job, he also had to leave his job because they wouldn't allow him, once he'd had a heart attack, to work up on the girders. So I just think we need to consider there are other financial harms to people who have smokers in their lives. That's all. Thank you.
Thank you, Dr. Gogo, for joining us and for
Thank
your
you
work.
for having me. And I'm always available if anyone has questions, and I will actually email these slides to Scotia.
Thank you, and we'll post them under your name for today. So we have further testimony on this topic next week. We are going to stop our shared committee work for today, but I just want to let folks know that we're going to need to move from learning mode to closer to decision mode on education finance issues. And so flagging, if folks want to dive deeper on things, and I would ask you to dive deeper on things on your own for the rest of the day today. Encourage you to really just go read anything that Julia Richter has ever posted on her website. You can just search by witness. But if you want to go deeper, the People Waiting Task Force report has a lot of depth on issues that are slightly separate from the statute that are worth looking into, sort of other issues we considered. The report on moving to an income base has a lot of depth that's sort of separate from the decision on whether or not that's the right thing to do. There's a lot of really great modeling from JFO about what happens when we sort of pull on one lever or another. That bubble we've talked about is really well explained in that report by Julia. And most recently, the 2023 report on Vermont education finance has a really interesting explanation of the way the yield can be used as a tool for quality education. So invite you to dive into all of those and whatever else you find in the meantime. We will be back here on Tuesday